Bismillah ar-Rahman ar-Rahim. Hello, everyone. Again, we are with the brilliant star of the cataract surgery, Professor Steve Arshinoff, the professor of ophthalmology, Toronto University, Canada, and he is the president of the International Society of Bilateral Cataract Surgery. Everywhere, all over the world, there is a continuous debate about the bilateral simultaneous cataract surgery. And many of surgeons everywhere are doing this technique, but unfortunately, they are out of the guides. These guides were put by the society, and we have today the president of the society and the founder of this idea and the founder of these guides to do it in the right way. So this video will show how to do it safely and properly. If you are not doing it, if you are not doing it by this way, you are doing a crime. So this video for who are doing the bilateral cataract surgery in my country, Egypt, and also in the other parts of the world, in this on their own ways, not on the ways of the International Society of the Bilateral Cataract Surgery. So we are so glad and honored today to have in Ziada Eye Academy Zoom meetings about the anterior segment surgery and the cataract surgery. Today, we are talking with Professor Steve Arshinoff. Thank you, Dr. Steve, for accepting my invitation and getting us the precious time from your off day and your holiday. Thank you very much, sir.
Thank you, Dr. Ziada. So this is an interesting topic because I began to do routine bilateral cataract surgery in 1996. And I think I've done something like 12,000 eyes as bilateral cataract surgery. So I have lots of experience. And now there was a long period where people were very reluctant to do bilateral surgery, and had all kinds of want to do it. But I think the main reason was financial. In many jurisdictions in the world, you are paid significantly less for the second eye. And for example, in the United States, where in many places, they get only half the fee for the second eye and the center gets half the fee as well. It's not financially reasonable to ask a surgeon or a center to forego half of their fee because they might go under because they only have a 20% margin by doing routine bilateral cataract surgery. That wasn't the case for me, and there are many countries, Sweden and many Scandinavian countries and Spain, where people were doing a lot of bilateral surgery, and we were trying to figure out what's going on in the world, why they're doing it and not doing it. And then along came COVID, and suddenly it turns out that all of the countries where they were paying people less to do bilateral surgery then placed into their requirements very complicated cleaning routines between one eye and the next. So you had a half an hour turnover time. And then people find that instead of doing 20 cataract cases in a day, they could do 10. So they were suddenly very interested in doing bilateral surgery because you can do the same patient on two eyes and you may not do 20 cases, but you can probably do 16 or 17. So all of a sudden, everyone wants to have seminars and discussions on bilateral cataract surgery. And it's now December the 4th. But since April the 1st, I think I've done 50 or 55 webinars all over the place asking for guidance on how to do bilateral cataract surgery. And some of the places that are more honest tell me, well, we want to do, but we want to cut a few corners because it's expensive to do this and that and the other. What do you recommend about doing bilateral cataract surgery? So I'll try to keep this simple. So first I'll talk about the things you want to do before you undertake bilateral surgery. And the first thing you want to do is you want to make sure that your complication rate in a routine cataract is essentially zero. No one's ever zero, but it should be zero unless something peculiar happens in the operation that gives you a surprise you don't want and you have some kind of complication. So the things you have to know are, one, you must be able to dilate pupils intracamerally because someday someone will walk in, perhaps a female who's been taking some psychiatric drugs, have the same effect as Flomax, but you shouldn't tell you she was taking these drugs 2 years ago. and you dilate your pupil, you put the phaco in the eye, and in 2 seconds, the pupil is minuscule and not responding to your surgery. So you have to be able to dilate them intracamerally, to use hooks or to use different things, and be confident that you can do this and you won't basically mess up the case because it didn't meet your expectations. So that's the first step. The second thing is you have to learn how to use OVDs and have different OVDs in your armamentarium. Now, I'm not telling you that you have to use the world's most expensive OVD for every single case, but if you have a difficult case that sort of demands from you to use a technique with another OVD than your usual one, you have to be familiar to how to do that, because you can't sacrifice the eye because you're going to save $10 on the OVD, or because you only keep one kind of OVD and didn't bother to learn about the other one. So I think it's incumbent upon us as surgeons, before we do bilateral cataract surgery, to know how to do really whatever kind of case will be coming to us. And then we have to also know how to set our phaco machine. So for example, a couple of weeks ago, I went into the operating room and lo and behold, my settings had been erased from the phaco machine. Well, if I didn't know how to use the machine and how to reset it, then that would be problematic because I would not be able to have the settings that I like, which are continuously variable pulse. Then it would not work the way I want it to work for a lot of the cases I had booked that day. But once you sit with your machine and you play with the dials when you're not doing a patient and you learn how to do it, then you can walk in, and if something has been changed, you can just change it back. You should not be afraid to change the flow rates, the aspiration. You should know how all of these things work so you can change them when you feel like it and you think that that particular case needs it. You should be comfortable in doing IA with different hand pieces, be comfortable with one hand pieces or with two hand pieces by manual, so that you're not afraid to change when something happens in surgery. You should know that your biometric calculations are accurate so that you go along and do a case and you know that you're going to be very close to your target refraction. And then you should also know that if you decide to put a lens that you have to in the sulcus or capture it in the capsulorhexis, what the difference will be in the calculation of that lens, so you can just ask the nurse for a lens and go ahead and leave the patient knowing that they came out well and not that you're going to have a problem. You should use intracameral antibiotics. In our society, one of the firm stances we've taken is that there are now more than 10 million eyes having been done in studies around the world with intracameral antibiotics, and generally speaking, you reduce your infection rate by about 8 times. We think that it's really not ethical to not use intracameral antibiotics when we know that you can reduce your risk of infection by that much. And it's cheap. In most countries, you can get moxifloxacin very reasonably. In almost every country, you have a moxifloxacin available that you know is safe to inject intracamerally, and I can't see any reason not to do it. You must make sure that when you finish the operation that you seal the incision, that it's sealed, that it's not leaking, that you won't get the patient getting an infection 2 days later because the wound leaks. So you must have a protocol of how you seal the incision and to check it at the end of surgery without spending like a lot of time. So you can do it in a few seconds and you know that it's going to work. And then you must have ordered follow-up routines where you as a surgeon sees your patient so you know that they're doing well. You can't, when you do bilateral surgery, expect that someone else will tell you how the patient's doing and be sure that everything is okay. It's only when you look at your own surgery and you see what you've done and you know the parameters of your surgery that you can assess if it's really good or not. When you do all that and you start doing bilateral surgery, then it's fine. So the next points. I always do the left eye first. And I chose the left eye because in the operating room in which I work, the left eye is always furthest from the door. And if you do that, you can be operating on your left eye and the nurse can be bringing in towards the end of the case instruments and stuff closed and sealed for the right eye without interfering with what you're doing. And then when you finish the left eye, you can put the drops in, get everything ready, take the instruments out of the eye, and then turn your attention to the other unopened covered tray without having to contaminate it. So you're sure that you're using completely separate sterile instruments for the second eye. There have been about 10 cases around the world of bilateral endophthalmitis. In every case, something was done wrong, either in the surgery, in the sterility, or in one case, it was the building that had a problem with the construction of a new building. But you have to be careful and you have to do everything you can to avoid getting contaminations and making sure you're certain. If you do always the left eye first, always the same one first with left or right based upon your room, then the nurses know when you start surgery which eye they're dealing with. They'll know which lens to get, what you want to do exactly, and they look at it as separate eyes, left first, then right, every single time. So the risk of having errors is much less. So that being said, what I want to show you now is a turnover of a case we did this was done in, I have a private center now. This was done in a regular hospital operating room, so it's nothing unusually special. The neurologists are regular nurses that go from room to room, and they did this just fine. So I want to show you this case, and I'll share my screen, and then I'll show you the case and what was done. So here we're sharing the screen, and let me just put this up. Okay, so you should be seeing it now, and it's already started. And here I am finishing the first eye. Notice it's the left eye. So lift the microscope up, take out the speculum. The nurse beside me has just helped me finish the first eye. The nurse across the room on the other side of the room has getting the other tray ready, but notice it's covered in the plastic containers that have the sterile instruments. She hasn't touched anything. She has done nothing with this eye. I'm giving the patient now their post-op drops, while the nurse that just finished my case is taking apart the instrument tray from the left eye. And she's putting it away so they can take it to cleaning. And then she will take off all the draping of the machine. And she's going nowhere near the other nurse. So the circulator is helping her attend to cleaning up the first tray. I give the patient the drops. Now I'm giving the patient some anesthetic for her other eye. I position her head again. The first nurse is giving me the prep for the second eye. And I will come back and I will prep that eye. I want you to notice that even the prep is not ridiculously elaborate. I don't cut the lashes. I just want to clean the eye and do the case. Every time you are too elaborate and playing around, you actually increase the patient's risk. Just make it clean. Use the drape to overlap the lashes, but don't fool around for too long and release bugs. Now the nurse for the second eye is already preparing the phaco machine, but the other nurse isn't going there. I finished prepping it. Now you see I take this tray and give it back to the circulator, take off my gown. Everything's taken away. Nothing has touched the other tray or anything else. The nurse from the first case will take my gown, put it away, take that whole set of dirty stuff and take it away. Meanwhile, I will now come towards the patient after being regowned and regloved. Notice everything now comes from the new tray with the new nurse, and the other nurse has nothing to do with it anymore. And she's actually going to walk out of the room. Everything's left alone. And I will get my gown ready, and I will come and I will cover the eye and start the case. So now we bring this set of instruments in. Notice nothing has been uncovered. It's all still covered. We bring it in. She will open it and get it ready for the surgical procedure for the second eye. I drape the eye, pulling the upper lid up with the glue from the drape. Get it ready, incise the drape. Notice it's done without excessive complexity to make it simple and neat, so it's clean and not contaminated whatsoever. And then we're going to start the case. So the main point here is to see how everything is kept completely separate. And even with one machine we use a second time, we have two nurses, one finishing one case, one starting the other, and no one touching anything that came from another tray. So the circulator is now finishing, getting rid of everything from the other eye, and she will change her gloves and things and not go near anything that we're doing for this eye until she's changed her gloves. So now we're ready for the case. The phaco machine is brought in, the circulator comes there, the scrub nurse comes close, and we're all set to go. So the point of this is I always do the same eye first. I have an organized system where nothing from the first eye goes to the second eye. Everything that was set up for the second eye is kept away from the finishing of the first eye until we're ready to change it and come back and do the other eye. And that way you can keep it completely sterile in going from one eye to the other. Okay, so do we have any questions?
Okay, thank you, Dr. Steve, for this for this great presentation about this hot topic, as I mentioned before. But I was happy while watching this this motion inside the OR. You are doing a lot of things. Actually,
Right.
actually inside the OR, we are just wearing the gloves and sitting on the chair and going to back, and is the nurse is doing everything, but you are helping in all steps. This because you are just helping or to be assured about the this trial things to be bought and to be done properly.
Mostly because I wanted to be sure it's done properly. I find nothing works better than leaning over them and watching what they're doing.
Yeah.
Because, you know, in hospital, like it's now okay in our private center, but in a hospital, they tend to bring in different nurses sometimes.
Yeah.
And they bring in a nurse who hasn't done it. If you don't sort of lord over them and say, do this,
Yes.
they're going to make a mistake. So
nurses,
in our private center, I actually have to do less because by the time I turn around, it's already done. Because they've done, you know, 1,000 of these cases with me, the same nurses, so they don't have a problem.
Yeah.
But in a public hospital, in that case, 2 of the nurses there had done many cases, but one of them hadn't done many cases. And so I want the one who hasn't done many cases to stand in the corner and stay out of the way, and I get everything else organized and then let her come and do it.
Different nurses with different minds and IQs. So
right. Well, they were all those 3 are very smart nurses. They're good.
Yeah. Nice, very nice. I'm just kidding.
But, yeah, but it's true.
But the same nurse in the private center, she knows about your way of dealing with your surgery. So she's saving, like the program on the Infinity or the machine. She is also knowing about your steps, about your preference in the surgery.
Right, so she checks it before I have to look. So the nurse that I have now, it really is a pleasure because I know that she turns on the machine, whichever machine we're using, she checks it, she knows it has my program, she knows that the program works. If it's off, she can check it and fix it before I even know she's done anything. And she says, okay, I'm ready. And even now, when we do the cases, what she's learned from me is I want to be absolutely sure we have the correct lens for the correct eye. So she speaks up, and to the circulator, she'll say, we're doing the left eye. It's a plus 23 diopter so-and-so lens. Make sure you give me that lens before we even start the case, right? And then as we go along, she'll say, hand me the lens. Is it this a plus 23 diopter? And then she tells me this is a plus 23 diopter. So I hear her talking, and she's absolutely on top of everything. It makes my life a lot easier. And I have on my microscope, I have a little table of which patient, which lens. So I look up and make sure she's saying the right thing. So we have never made an error in thousands of cases.
Yeah, I'm doing the same in the public hospitals. I'm writing a paper at the beginning of the day, the name and the IL power, if there is hepatitis C or not, and so they all in and I'm reviewing everything with myself before surgery, because I may be stuck with the situation at the end. If the IL power is 23, for example, and you will find at the end of the surgery the nurse is coming to you and shouting, "Doctor, this power is not available today."
Right.
And the patient is under local anesthesia. So if you can even if you can manage this problem, but it's not wise at all for the patient to hear this this issue in his language, because whatever you have done, whatever you have managed, the problem will be still inside this patient.
Right. It just got messed up, right?
Yeah. Okay. If he
the advantage we have in our private center, by the way, is my scrub nurses will check every IOL the night before and make sure. And before we start the case, they tell me the next patient coming in is this person. For the right eye, we have this lens that you've ordered. For the left, we have this. And I have it on my sheet like you have. I look up and I say, that's what we have. Right, correct.
Yeah, it's always done in the private center because they are well trained about that. There is double and triple checks before incising the cornea. But the public hospitals not well trained,
Right.
because
Not quite as good.
yeah. You may find that the nurse who is helping you today, it was yesterday in the orthopedic surgery and so they are rotating. So I noticed that you changed the cassette and the handpiece, not the tip, the handpiece and the old tubes.
We changed everything.
Between both eyes. Yeah.
Right.
You change everything.
Everything.
I'm repeating this sentence again and again. You are changing everything.
Right.
Like if you are starting a day, not a case.
Right. It's like doing another patient.
A new day. Okay.
Yeah.
And this is the issue because they are not doing such a this.
Not everywhere. And everyone talks about the fact that, you know, it costs money, but you have to look at it. You're doing the patient's two eyes. If you're doing this patient and another person, you change everything. So why not change it for their second eye? They're coming for a second operation, so you change it. And that's part of the problem, where in many jurisdictions, they will pay less for doing bilateral surgery, which is ridiculous. They should simply pay twice as much, because if you come to me new on cataract surgery, I should do what's best for you, whether it's two eyes one day or one eye one day, one later. Whatever works out better for you should not be an issue. But as soon as you start introducing differentials of money for different kinds of cases, you bias the surgeon's choice of what he's going to do with money. And I think that's just bad medicine. It should be the same no matter what.
Yeah, right. Okay. The other question about this issue is it becomes a routine in your life practice, I think, but the COVID-19 increased this the need for this on our side. As I told you, the practice of the bilateral surgery, which I have seen, it's not totally with the guides with this technique. Even the surgeon who I attended his bilateral surgeries in that list, he just changed the gloves, So I was objecting this behavior, and so I was talking with you in the last meeting about these issues in details, because I know that there are a lot of persons, a lot of surgeons who are doing that out of the protocol, and the others are just objecting. So I was keen to show it in the scientific way, not just objection without evidences why I'm objecting. And if you are trying to do it, you have to follow these instructions and these guidelines to be a successful or the proper surgery.
So here's my honest feelings. It depends on the operating room and how you do things. So one of the people who I always regarded as someone I should try to learn to emulate was Howard Gimbel. Howard Gimbel is a phenomenal surgeon. I think he just retired and he's in his 80s. He's worked for a long time. Yeah. So I went to watch him. So Howard Gimbel never gets out of his chair. He sits there and does it, and the nurses do everything to get it ready. So Howard Gimbel only changes his gloves between cases. He touches nothing with his gown except the chair. And he puts his gloves out and he touches nothing. That's fine. If the surgeon is sure that he's not touching anything with the patient or going near them, and the nurse drapes them and everything else, and he just has his fingers out there, it's okay to change just your gloves. So I think you can't be so critical of someone until you go and you see what they're doing and how it's working. So if you have a place like Gimbel did, and you're just sitting there and they change your gloves and you reach out and do the patient, that's fine. But if you're doing what I was doing and getting up and getting things and you could be touching the patient or this, then I'll change the gown also.
Yeah, okay, but we have to do that to decrease the opportunity for the infection, especially this patient is a bilateral patient, not unilateral one. I think the incidence of endophthalmitis in such patient will be the same for the unilateral surgery, but it will be
actually lower. Yeah. In every study that's looked at bilateral surgery, the infection rate is lower than unilateral surgery.
It's lower because of the overcare?
I think it's lower for a few reasons. One of them is none of us started off doing bilateral surgery. So when you go into an operating room and you say, we're going to do bilateral surgery, the nurses are terrified.
Okay.
And when they're terrified, they're much more careful. So even the nurses now in our private, we've done thousands and thousands of bilateral surgeries, they're really careful. They make sure they don't touch anything. Everything is here. Everything is changed, is put on the side. They're really cautious. When you watch them do one case, often they're in a hurry. Go get the patient, bring them in, do this. They're not quite as careful. So I think that helps. I think we use intracameral drugs in every case in bilateral surgery. In some places, they don't use it in all their cases. I think that helps. I think also you don't have residents doing bilateral cataract surgery. The people who do bilateral cataract surgery are those who are more experienced and are better surgeons generally. So they have a lot of experience. And so those surgeons tend to have a lower infection rate to begin with. So then if you look at them, you see that you're getting the infection rate of the elite surgeons, not of everybody. So it's probably a bit lower. And then the other thing that you notice if you do bilateral surgery is the second eye is always easier. Because, you know, if you deal with a person, my left eye is more like my right eye than it is to anybody else's in the world's eye, right? It's most, so when you do one eye and you go and do the other eye immediately, the second eye is always easier. So if you had a little posterior pressure, you put a little bit more viscoelastic in. If you had a little bit of this, you do this a little bit more. And you just make little adjustments where you know that the second eye is always easier. And everyone who does bilateral surgery will tell you the second eye is always easier. And the patients tell you. The patient will tell you, they say, you know, doc, I was paying attention, and I think it took a minute less for the second eye.
Yeah.
The truth is, they're right, because it's a little bit easier.
It was so quiet.
Yeah.
I was enjoying the operation.
Yeah.
I didn't feel any stress or any anxiety about the patient.
And the surgeon is less stressed. If you just finish the first eye, you know, you sit down to a patient, no matter what you say, everyone's always a little bit apprehensive. What are you going to expect? How's this going to go? After the first 30, 40 seconds, you have an idea. But in the beginning, you never know if they're going to lie still, move their head, all kinds of stuff.
Yeah.
But for the second eye, you know exactly what's going to happen.
Yeah.
And you're just, everything's more calm and it's just easier.
Yes, expecting.
Yeah.
Expecting all the steps, so she's calmer. After the first meeting was, I have received a lot of questions, a lot of comments about this technique, but when I discussed these points with these professors and these colleagues about this technique, I found when I discussed with the person or the surgeons who are doing this, that they are just doing this for 2 points. One of them is financial. They are caring about the patient not to escape, to do the both eyes for this patient, because he may think to do the surgery with after a time, he may go to another surgeon. So it's financial issue. It's not a scientific or the patient's issue. The second one may be the ego. This surgeon is doing something different, something strange to the patient and to the other surgeons. Just 2 causes. I didn't find any other indication. I'm not talking about the emergency cases. I'm not talking about the handicapped cases. I'm not talking about the traveling patients from other countries to do cataract surgery. I think they are totally indicated for such patients if they don't have the ability to come again, the ability to stay a long time in this time. So the recovery will be the same for both eyes, and the entrance for the OR, and it will take all fear and all stress just one time. So there's no comparison between eyes. This is one of the benefits, because the patients are comparing all the time between both eyes. The first eye, I didn't feel any pain. The first eye, I didn't get any scratch or itching, and so blah 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 blah. Yeah, and a lot of.
But they compare them with bilateral surgery too. I have many patients who I do, and both eyes can be 20/20, and they'll come and they'll say, you know, doc, when I look at the chart, it's a little sharper in this eye than this one.
The same.
But you know, it's never going to be exactly the same. It's going to be close, but
Yeah.
because our lenses come in half diopter steps, so you know, it's not, even if both refractions are plano, one will be, well, a little bit hyperopic plano, one will be a little bit myopic plano, but you know,
Yes.
maybe minus 0.12 or plus 0.1,
Yeah.
but it's not going to be exactly the same.
Okay.
And I just tell them that, you know, that's just life. Nothing is exactly the same. Your right and left arms aren't the same.
Really,
But they're both good.
really, it's a fascinating procedure. I'm believing in it, really, but I will not do it. Otherwise, I cannot take the old protocol points. If I find in myself able to do it by this protocol, keeping all guidelines, I will do it. Otherwise, I will not, because if I do it in the right way, I will be comfortable, and I will not blame myself if anything happens. Otherwise, I will not excuse myself. So
Good that you're careful.
yeah,
We're supposed to be careful as doctors.
yeah.
We're supposed to care about the outcome for the patients, right?
I told you before, I have done it twice for two patients. One of them is handicapped. The second patient was traveling from Saudi Arabia and had just 4 days. So I have done bilateral surgery, but according this protocol, changing everything. And I paid a lot for the center on such a day, but this is the right way. You know that the regular procedure, the regular cataract surgery here in Egypt, and I think everywhere in different countries, that all patients may be done with just one cassette. There's no changing for the cassette for every patient even. I have to be clear, just one cassette for the oldest. Maybe change it if there's patient with hepatitis C virus positive.
Yeah.
Just in this situation. Otherwise, the cassette will not be changed except at the end of the list. For the second day, we'll put another one. But the bilateral surgery, it should be done in this way. So I think in the previous video, I asked all questions and all points to be cleared about this technique. So thank you, Dr. Steve, for giving us this practical or the live presentation today about how to change and turn over from one eye to the other in the right way. And I will put the link of the previous video in the first comment under this video on the YouTube, my YouTube channel, Arshinoff Ziada iTube. For anyone likes to know all the points about the bilateral simultaneous phaco surgery and all topics and all guidelines and all objections, and how Professor Steve replied to all these points. Thank you very much, and I cannot express my gratitude and respect to you. Thank you.
Well, thank you very much. It's always a pleasure.